Hello, and welcome to a session with Dr. Siegel, Dr. Shayna, and myself, Daniel Tavigman. My name is Daniel Tavigman. I am the owner and operator of Gold Standard Psychometry. We train psychometrists for clinical psychologists, among other things. And so today what we're doing is we're going to interview Dr. Jonathan Siegel and Dr. Shayna RWI. So Dr. Jonathan Siegel is a clinical psychologist specializing in counseling and rehabilitation. He's come up with some new measures and some new ways to measure addiction, which has been very interesting. We're going to talk to him about that. And Dr. Shayna RWI is a clinical rehabilitation and neuropsychologist, and she's going to be part of the discussion just to try to elevate it a little bit to get that psychology stuff that we want. So Dr. Jonathan Siegel, you are the head researcher and driving force behind this new measurement system called the Rehabilitation Wellness Index.
Yeah, it's called the Rehabilitation Wellness Inventory, and I'd like to just talk a little bit about the background, how this came about. For the last several years, we were providing a measure of depression and anxiety to individuals who were entering into a treatment program for problems with drug and alcohol. And we found that people who have problems with drugs and alcohol often have mental health issues, which either precede the addiction or are consequent to it or associated with it. And what we discovered was that it was important to look at mental health issues before and after people enter into the treatment program. The Rehabilitation Wellness Inventory was designed to capture, in a very efficient way, elements that are associated with addiction and mental health so that we could gather meaningful and relevant information from these individuals who are entering into treatment programs before as well as after treatment to see the effectiveness of the treatment programs.
Cool. So I'd like to get to know you a little bit more as the person that is driving, like the driving force behind this. Where did this idea come from? Why did you come up with it? And is there actually a need for us to measure addiction? And like, why can't we just say, hey, are you addicted or not? Like, why do we need to do testing? Why is this important?
It's a great question. There are many rehab programs throughout North America where people will go to live at a home for 28 days, 60 days, 120 days, to look at many mental health issues associated with addiction. And when you look at the websites for many of these rehab programs, they talk about having an empirical approach, that they're taking a scientific approach to evaluating the effectiveness of the treatment program. When I reached out and did some inquiries, I found out that there wasn't a standardized system in place that people have for really evaluating whether or not the treatment programs are working. And what does it mean for a treatment program to work? It doesn't mean just stopping using alcohol or stopping using drugs. The big picture is that addiction, whether it be to alcohol or to illicit substance, is always associated with something missing for a person, either psychologically or spiritually. And when I talk of psychologically, I'm talking about how people think, feel, and behave. And when I'm talking spiritually, I'm talking about that sense of being right within oneself and also values. Am I right with myself with respect to my honesty, my integrity? Do I feel good about myself? Do I feel at home in the world? So addiction is the symptom of a problem. it can become a problem in itself, but it often is a symptom of mental health issues. So when you go to a treatment program, is the goal only narrowly to just stop drinking in a maladaptive way? Is the goal to stop using illicit substances? I think that it's much more to it, because for many people who have problems with addiction, the alcohol and the illicit substance were the solution to a problem. But that solution became a problem in itself. I know of individuals, having counseled individuals, who said that the problem wasn't the alcohol or the drugs. The problem was when people didn't have the alcohol and the drugs. Because at that point, what are you left with? Left with restlessness, irritability, and discontent. I think the lack, and the opposite of addiction is connection. When people are in a, I mean, we all as human beings have variability of emotions. Sometimes we have better days than others. But it's pretty common for individuals who have problems with alcohol addiction, problems with alcohol addictions, where it becomes progressively problematic and interferes with people's relationships or work. These individuals are in a state of being restless, irritable, and discontent. What's it like to live inside that? It's very uncomfortable. Well, how do they satisfy that? Get some kind of quick fix to feel good. So we realized that to determine the effectiveness of a treatment program, we can't just look at whether or not people are stopping using drugs or alcohol. We have to look at, are they getting better mentally, spiritually, psychologically, emotionally? And so we realized that what was important was to tap and look at items that were relevant to mental health and well-being. And what I think as a psychologist is particularly important is to be able to gather that information in a way that's meaningful and in a standardized way, a scientific way. If someone, Bob, as an example, or Mary, these are hypothetical names, people who go into a treatment program, and you want to determine if the program was effective, you can ask Mary, or you can ask Bob, you can ask any of the individuals. And that's good qualitative information. But when people talk about empirically based proof that a treatment program is working, what has to happen is to have what's referred to as a standardized process. Some people use the term objective. What that means, from a practical, concrete term, is that everyone is given a measure, the same measure, of that taps into mental health and well-being before and after treatment, so that you can see whether or not this quantitative information, which can be analyzed statistically, whether or not the treatment program has been effective by chance alone, or there's a real effect. One more point I'd like to make about this is that individuals who are coming into treatment are often at a very low point in their life. They've hit a bottom. And people have different kind of bottoms. For some people it's jail. For some people it's a loss of a relationship, losing a marriage, losing a home. For some people it's this element that they're sick and tired of being sick and tired. For some people they're experiencing chronic anger. Everybody has a different bottom. But there's certainly enough of those individuals who are coming to treatment when they seek out inpatient rehabilitation treatment programs, that they've gotten to a point where they're obsessing, constantly thinking about, obsessing preoccupation with getting the drug or the alcohol. They're in a state of distress. And so we realized that those individuals, when they're first coming into the treatment program, their attention is a bit compromised. They can't sustain concentration and attention and focus for any prolonged periods of time. So it's important to develop an inventory that allows people to be able to complete it within a very short period of time frame. In this case here, the rehabilitation wellness inventory can be completed within 10 minutes. And the information that we gather, which is again related to mental health and well-being, is gathered in a way that can be analyzed using descriptive and inferential statistics, and so that we're able to analyze whether the treatment program is working and stratify whether it's differentially better for men, women, or different age groups. And what I get really excited about is that this process, which is automated and provides a report in real time, is particularly valuable for the therapist who is going to be counseling these individuals. And this information helps to structure the treatment planning process at the very outset, and also is extremely useful as part of the discharge process, where they're looking at what worked in the program, what didn't work. You indicated on this inventory that you strongly agreed that you were sad at the beginning of the program, and now you're disagreeing. That you tell us a little bit more what the transition was, any particular component of the program that was helpful. So the Rehabilitation Wellness Inventory is an extremely useful tool because ease of administration for the individual. It's able to be administered within 10 minutes, 10 to 15 minutes, and the information that's gathered is very targeted and helpful for the treatment professional for treatment planning and discharge. And as someone who is interested in science and looking at evaluation rigorously, and if people are going to use that we are empirically based, then the information does need to be analyzed using proper statistical methods, with gathering information pre and post, and doing the proper analysis. That's the foundation of science, and being honest with respect to, is our program really working?
Mm-hmm. So with the RWI, you'd be able to sort of, as a clinician, differentiate if, this person is, everybody's coming in with substance abuse issues, but maybe, Bob is coming in and a lot of his substance abuse issues have to do with feeling depressed and trying to numb that pain, whereas Mary may have interpersonal difficulties that she's trying to mask or deal with drugs of abuse, and then that will help guide the clinician into what areas we're trying to help the person with, rather than just saying the problem is the substance use and we just need to stop the substance use and then everything will be perfect.
Yeah, I think that characterizes it very well, in that we know that addiction is the fundamental problem, but within that problem, people are having different types of difficulties associated with addiction. For some people, there are interpersonal problems. For some individuals, there's a level of depression that's very deep. For some individuals, they are stuck and preoccupied with certain resentments. It's not uncommon that some individuals may not be taking proper care of their eating patterns, their sleep, and what this inventory does, it may not provide the clinician with the exact problem that the individual is having with any particular individual, but what it does do very effectively is it captures to what extent, how severe the problem is with respect to what's going on internally with the individual. And So, for example, the inventory is designed to see whether or not people's emotional states, how anxious a person is, how depressed an individual is, how angry a person is. So it has these different dimensions. And it is also looking at how well people are feeling right with themselves and in integrity with themselves. And it also addresses some general issues related to mental well-being regarding how comfortable they are with other people, how are they able to be, are they restless, are they irritable, are they discontent most of the time, and how that affects their interpersonal relationships.
And then the hope is that because we have a better understanding, rather than looking at the person as substance abuse is the only issue here, then you can have more effective rehabilitative treatment, and then that will result in lasting improvements in their mental health and their substance use, rather than just sort of corralling them so they can't access drugs for 90 days and then relapsing upon discharge.
Yes. If a person is having to control their addiction, they're out of control. Because people who don't have problems with drugs or alcohol are not trying to control them. There's nothing wrong with alcohol for those that can handle it. It may be very natural for individuals to comfortably have one or two drinks and then stop. It's not the case for individuals who seem to have crossed a line. There's a saying that in the field of addiction that once a person becomes a pickle, they can no longer become a cucumber. And the idea being is that if you put cucumber in brine and dip the cucumber in brine, it just be a cucumber, and at one point it becomes a pickle.
Right.
And one then has crossed the line where the challenges, people are being driven to this substance to feel, to avoid unpleasant sensations of withdrawal symptoms. So the issue of alcohol, illicit substances, is for the most part related to other issues that need to be addressed. Mental health issues, it's when people are not feeling right with themselves, they turn to illicit substances to feel that sense of high, to feel a sense of ease and a comfort. And there's a certain group of individuals who physiologically are more predisposed to develop the problem or for it to become progressive. Getting back to the Rehabilitation Wellness Inventory, it's a tool. And the items, and I'd like to just, we've got some information on here regarding it. I want to give an example of some of the items as an example. And there are we have 5 different scales. We have a validity scale on here as well, to see whether when people are filling it out, they're responding consistently or inconsistently. Here's an item that will give an illustration of a mental health issue or a psychological issue that may be associated with addiction. I live with shame. Now, it's not as if it's only people who have problems with alcohol or addiction have problems with shame. It's not the case at all. We're human. We all, as humans, may have good and bad moments in our lives, and we struggle with internal feelings of conflict, or we may all have that at some point in our life. And being human can be challenging. Which way do I go in my life? Do I go this way or that way? How do I choose the career that's best suited to me? How do I choose a spouse or a relationship? So we may be torn in different directions. It just so happens that people who veer towards problems with alcohol and drugs, they deal with it that way, these conflicts, rather than perhaps in more adaptive ways. So a lot of the items on the Rehabilitation Wellness Inventory are applied to all individuals, but we've targeted this with other items that are also relevant to addiction. And the items on the Rehabilitation Wellness Inventory tend to be often associated with addiction. So, for example, for many people with alcohol and drug problems, shame is an issue. Now, how valuable is it for the therapist to be able to look at 50 items and to see where a person is answering on that? So when the person comes into the treatment program to begin with and they see that a person has said that I strongly live with shame, that becomes a springboard for a discussion to see where did that come from. Because people with, there may be, it's not uncommon for people with addiction to feel that shame, and then how does one address it in therapy? An example of another item. It addresses to what extent a person feels guilty about hurting others. In a 12-step program, which is there's different programs for treating addiction, but certainly the 12-step program has been shown through research to be of significant value as a good support system and for aftercare. It's one of the steps requires the individual to look at the ways in which they hurt other people. And sometimes the way we've hurt ourselves. Now that can be a hard process. I mean, think about it for a moment. How often do people want to look at how we've hurt other people? Sometimes all I can focus in on is how, let's say, you hurt me. But here's a paradigm shift. I feel guilty that I've hurt others. I may not have, a person coming into the program may not have even thought about that. The items on the Rehabilitation Wellness Inventory from the very beginning trigger a person to think in ways that they perhaps wouldn't even thought of thinking about. Feel guilty that I've hurt others? No. I disagree. But then that's useful tool for the therapist also to know, because it's probably not the case, because perhaps at all of us at some particular point in our lives have hurt others, and either intentionally or unintentionally.
So it's not just that, like, there's not like an answer like, yes, you have to feel guilty, no, you don't have to feel guilty. It's much more of like, this is a question that is significant to like the holistic view of addiction, and then the way they answer it, it gives the counselor or the therapist the opportunity to talk about these things and to look, to zero in on and see what's happening here. And so they get this like statistical analysis that you've been talking about in the report that's generated, but then they also have this platform or this jumping off point to continue and to explore the treatment, as for them to be able to use that as like the entry point for treatment.
Yes, and to review and to summarize, the Rehabilitation Wellness Inventory is valuable for at least these three purposes. One, for gathering information for treatment planning for therapists, for discharge. And when we talk about statistics, and especially inferential statistics, which means is it statistically significant? Is the program working? We're not just talking for the individual. When we're talking about statistics, we're aggregating the data, and we're looking at the data for all the individuals who attend the treatment program,
right,
and analyze it with 100 individuals, 200 individuals, generally at least 30 as a minimum, but we generally like to have the larger the number the better. So the descriptive statistics are used by the therapist. The inferential statistics are used when we gather the data and collect it for all the individuals in the program, and we begin to look, do some people do better than others, certain age groups do better than others, and think about how valuable this information is for the directors or the owners of the rehabilitation programs, because not only do they now have data, internal data, where Bob is saying the program worked or Mary is saying the program worked, we now have quantitative data to show precisely the ways in which the program worked or didn't, in what way, and is it statistically significant. The data that we have collected for the past couple of years with one of our clients who runs a private rehabilitation treatment program shows convincingly that mental health issues are associated with addiction and that the treatment programs work. And you would hope that it would when people are spending that time and investment and money.
Mm-hmm.
But isn't it good to have hard data, quantitative data that shows that?
Mm-hmm.
As a researcher, I think that's particularly important. The foundation of science is it subject to empirical investigation? And I was coming back surprised that many rehab programs on websites will talk about using its empirically based data, and when you ask them what systems they have in place for gathering that, doing the inferential statistics, regrettably there isn't. And there is not a standard in the industry, or there aren't guidelines in the industry. So an industry standard has not yet been set, and we're hoping.
This is kind of cutting edge then.
Well, I'd like to suggest that it's important, and I'm hoping that people use the Rehabilitation Wellness Inventory because I think it has tremendous value, but I'm also suggesting that whatever inventories you're using, please employ a standardized process so that when you make assertions or claims that it's empirically based, do the statistical analysis so that you can actually prove that it's working.
Yeah, I guess it occurs to me as a clinician, I can see how you may end up in a position where you'd say, we use we're evidence-based because we use, let's say, cognitive behavioral therapy, right? But if you're not doing systematic intakes and you don't really know what the person is struggling with, particularly with things like guilt and shame, people don't usually come to you telling you, I have issues with shame, because they're ashamed, right? So if you're opening up the door to finding a variety of different pathways, then you can use evidence-based treatments like cognitive behavioral therapy or other therapies to address the issues that the person actually has, rather than intuiting that the person must have these issues because they have addiction, and then just give them a cookie cutter, approach where, okay, we're gonna, teach you whatever it is, how to manage social anxiety, right, or whatever it is.
Yeah, I think you've touched on something really important, where you're making this distinction between evidence-based tools and almost like evidence-based treatment, or where you can use the CBT, which is evidence-based, but then are you yourself within the realm of evidence-based, or is your overall programming or the way your approach is, and your diagnosis combined with the circumstance combined with the counseling, is that on the whole, is that evidence-based?
So I think we usually talk about that as evidence-based treatments would be is this protocol of treatment based in evidence versus evidence-based practice, which is sort of more generally is the whole approach that we're taking here, evidence-based, and doing evidence-based assessment, which is what the RWI is a part of having a globally evidence-based practice.
And I'd like to return to the phrase evidence-based. What does it mean? And the reason I'd like to do this is I teach statistics as well, and because it has not always come as easy to me, and I struggle with it, work with it, but I enjoy it so much, the discipline. I have discovered that there's a way of approaching this so that it doesn't seem overwhelming, and and that it's too abstruse to understand. So what is evidence-based? Evidence-based at its essence means that we need to collect the data, the information, to actually show that it works. That's its essence. And the way to do that is to collect the data, organize it properly, and analyze it using statistical procedures. Once one does those procedures, whether it's with the Rehabilitation Wellness Inventory or any other inventory, it's the protocol of doing that process that allows it to be called evidence-based. Because the question is, where's the evidence? How do you know that people between the ages of 25 and 35 coming into treatment programs are doing better than individuals from the ages of 45 to 75? Where's the evidence? Here's the evidence. We have 100 individuals. We've collected the data. We've done descriptive and inferential statistics on the data, and this is the evidence. And one more point is that people often refer to, when Dr. Nussbaum was referring to evidence-based cognitive behavioral therapy, what I interpret that to mean is that other researchers, or if you look at the research that's done in the literature, which essentially is looking at individuals who have received cognitive behavioral therapy versus another therapy, and data was collected and analyzed, and the inferential statistics was done, the researchers in the literature have come up with the conclusions that this particular modality, based on this evidence, is statistically significant. So I want to just keep on emphasizing this point that evidence-based means having a standardized process for collecting, analyzing, and interpreting data and using statistical processes. I feel passionate about this because I feel that especially in an age where people are talking about alternative facts, or we're living in an age where we're trying to understand what the truth is, I am thankful to my professors, and I'm thankful for those who preceded me, and I'm thankful for the whole field of science that has provided us a methodology to do proper analysis so that we can discover what's true and what's not true. And it gives me a measure of peace and satisfaction knowing that we have procedures in place to do this. Hundreds of years ago they didn't. And people would say, well, it just works. Whereas now we do have procedures in place to do that. And that's important. And I know this is a bit of a tangent and not related, but specific, but now when I think of this, I feel very strongly about it. When people look issues that are going on today in our society, was the United States election stolen? Mm-hmm. And then the question I'm always looking for is, well, where's the evidence to indicate that it was or wasn't? Why don't we, what is the protocol? Let's look at the evidence. But to look at evidence means you have to look at what systems were in place, where's the data? Mm-hmm. Why should that be so hard? Why should that be so hard? And with goodwill, and when people are doing things rigorously and honestly, and we can check each other's work, we then have evidence. Right. So I feel strongly about this process, not only because the Rehabilitation Wellness Inventory is a wonderful tool that we've developed, but my goal and vision for the entire industry is, whether they're using the Rehabilitation Wellness Inventory or any other inventory, and I hope that they choose to use ours because ours is very good, but whatever inventory you're using, please subject to a proper evidence-based process, a standardized process, a proper process that lends itself to quantitative analysis and proper inferential statistics.
And I think an important point, I completely agree with you, and an important part of that is that just because you are, using a treatment that works in general or has been found to work in the research literature doesn't mean that with this person today it's working, right? And it's important to know that the way that it's being implemented in your practice is effective, and if it isn't, what do you do so that you can be effective, so that you can help people?
Yes, it means holding ourselves accountable.
Yeah.
And sometimes not everyone is eager to be held accountable. It may just be easier to not look or see. Is the treatment program working well? Well, Bob says it is. Must be. Well, let's examine this. And it applies to any field really of science and medicine, whether one's talking about vaccines or other medical procedures. It is important to look at the research, the data, and to examine it more critically and properly. And your point is extremely well taken, because just because it's worked, cognitive behavioral therapy as an example, the literature has shown that it's worked with these particular groups of individuals, well, maybe it's differentially, does it work with the client that's in my office?
Right.
And if it's not, how do I adapt and adjust it? But the issue is being held accountable. And I like that idea of accountability. And it applies whether one's going to the gym or in any field, but
Yeah,
holding ourselves
especially,
accountable.
I think especially when you're working with vulnerable populations, which I do believe addicts are kind of definitionally within that space of vulnerable populations.
Certainly.
We do want, sunlight is the best disinfectant for us, or for people to be able to see, like, do these treatments work? What is the change among the people?
And that's what you would expect in other, in other fields of health, right? So if, a physician is putting a person on a blood pressure medication, that there is evidence that this blood pressure medication is effective for reducing blood pressure, the doctor still has to measure that person's blood pressure and make sure the blood pressure is going down and change the treatment if it's not working. Right? And that's not seen as a failure of the doctor if the first medication that was tried doesn't work, or a failure of the patient, right? This is just a part of the procedure of treating people in an evidence-based fashion.
Right. It's an iterative process.
Yeah.
And again, the Rehabilitation Wellness Inventory is a tool before and after treatment. And I know of individuals as a clinician, and I know of individuals who have remained clean and sober, or have not used, who had a problem with alcohol and chose to remain abstinent, or with illicit substances, and perhaps 10 years later they will relapse. One hopes that they don't, and there are systems in place to support individuals so they don't have to. I mention that because when people are holding themselves accountable to addressing issues honestly, the issues, for example, that are referenced on the Rehabilitation Wellness Inventory, for example, I feel emotionally balanced, is a question. Well, it's more common than not when people do have relapses in addiction, it's because they're not doing the necessary work to look at those mental health issues. They may have gotten better at one point, but just as there's a concept in statistics called regression to the mean, people may resort to or habituate to ways of being that they had in the past. And so it's important this issue of accountability is very important, because we live one day at a time.
Yeah, and I really do like that the RWI is not it's initially as an intake form, but it is some, and then the second time you take it, it's to see what progress have you made within the scope of the clinic that you're at. But then it can even act as a follow up.
Yes.
And so it's not like, okay, like some diseases, I think it's okay, here, take this pill. You take the pill, and then the infection's gone, and now you're healed, or your arm's fixed, and now you're done, and like that's it for the rest of your life. And I think for a lot of people with addiction, it is like, as you're saying, it's like a daily struggle, or something that's a big part of their life. And so to have that as a follow through, as like to keep going as a follow through, and it's not, and as we said before, it's not just measuring the addiction, but it's measuring the whole mental well-being space within them. It does provide some level of like vision, or what you're calling accountability, some perspective, like they can have almost like an outside perspective on themselves that they don't even necessarily have to share with others if they don't want to.
Yes. That is, the RWI was initially conceived and is currently being used primarily as a tool to support rehabilitation programs and evaluating the effectiveness of their treatment programs, evidence-based before and after treatment. But yes, you're correct. It becomes a tool that people can use at any time in their life as a way of checking in. I also want to point out, you had used the term struggling with addiction. There are moments in people's sobriety, or especially with 12-step programs, where that is no longer for people a struggle. In other words, the issue of alcohol or illicit substance is no longer a struggle, especially with the 12-step program, where there's a focus on looking at one's relationship with oneself, with others, and with the higher power of one's own understanding. And it's very, very common for individuals with 12-step program over time, some a bit sooner, some later, where they feel as if they've had this spiritual experience. And what I mean by that is they don't know why or how it's happened, but there's no longer a struggle with addiction. There may be struggles with a relationship, a spouse, a mother, a father, a brother, a coworker. Those issues may sometimes be a struggle. Why? Because we're human and we have these struggles. But having worked in the field of addiction, one of the remarkable elements that I've seen is that there are individuals who have what they call a spiritual experience, and by a spiritual experience is something that seems as if they couldn't have done it themselves, or it seems somewhat transcendent, or it's mysterious, but it's real for them, where somehow they're no longer thinking about the alcohol, they're no longer thinking of the drugs. It's as if that obsession has been relieved, and it seems to have been given as a form of a gift without necessarily understanding what that was.
There's a lot of like these kind of experiences, or like almost transcendent experiences that I think people report, and like it's weird because like it's like we're trying to like keep that out of psychology a little bit, but also it's also a fundamental part of a lot of people's lives and a lot of the way they see things and the way they frame it.
William James was a professor of psychology at Harvard in the late 1800s. Psychology. He wasn't a professor of spirituality, he was a professor of psychology. And he wrote a book called The Varieties of Religious Experiences. He was a psychologist who was trying to understand what were the circumstances, the conditions that seemed to be common amongst individuals who were going to have an experience which for them felt as if they were being transitioned to a different dimension. Not that their feet weren't rooted on the ground, but a good analogy would be looking at the atom. We know in the physics, an atom is a nucleus, and inside the nucleus there are protons and electrons I still remember that from my science class. And that there are orbitals around the nucleus of electrons, and there are different levels. Well, what do the electrons do, and how does chemistry work? Electrons actually go from one level, they jump to one level to the next. That's how chemistry works, where electrons will gain energy or lose energy, and they jump to different orbitals. I'm only sharing that because that's in the physical world, and what terminology or what reference point do we have for people having an experience that's spiritual? It's as if they're being transitioned to a different level or a different orbital. That doesn't mean they're still not
they could
grounded.
Be still physically here.
They're still physically here, but I mean, what metaphorical equivalent do we have for electrons going from one orbital to the next, for humans going from one? And we all kind of can experience it, or at least some people more so than others, but one hears, and this is in literature and movies, and where sometimes there's a point in people's life where they just kind of like wake up, and you know, midlife crisis, and whether people have addiction or not, they wake up and they say, wait a second, what am I doing? What am I doing on this particular track? And so there's this shift. And for some people, there's so much variety of people. People may have these transformative experiences that are educational in variety, and William James talked about that. They could be educational, they could be intellectual. Some people can just have a moment where it's like, and maybe a spiritual experience is just, wait, how come I'm not thinking about alcohol today? That's weird. Like that's really strange. And people have that. And sometimes there are these mysteries that even take place in counseling, where people feel better at the end of the session. They're not really sure why, but they feel better. It's humbling to realize that we don't always know exactly what works, but what's important is that it works when it does. And I just wanted to point out that the field of psychology has its roots. Spirituality and psychology, maybe there's overlap. It depends on how we operationally define spirituality. But there have been definitions that talk of spirituality in psychological terms, which is that there are emotional displacements and rearrangements. That's how sometimes it's spirituality and psychology are overlapped. What does that mean, emotional displacements and rearrangements? I'm here, but I seem to be wearing a different pair of glasses. Let's think of it in practical terms. And we're talking about addiction. And I think that this general principle is applied to people who don't have necessarily problems with addiction. But for people with addiction, it's particularly important because I think for people who have gone to drugs or alcohol as substances, and then people can go to there's other forms of addiction besides alcohol and drugs as well. There's many other forms. It could be food, sex addictions, gambling addictions, but we'll now really focus it onto drugs and alcohol for now. But what are people really doing? They're trying to feel right. They're trying to feel good inside. They're trying to feel normal. They're trying to be at one with themselves. And for some people, that is a spiritual experience where they, and they're not sure how it happened, but we do know that when people do certain things regarding their mental health and well-being, things get better. And that's why we have some of these items on this inventory. We do know that when people are ready to take some steps to look at themselves, and how am I the source of some of these difficulties in my relationship with my brother, my sister, my mother, my father. I never looked at myself in my part. It's easy for me if I'm pointing the finger to look at you, but It's very hard to look at myself. And the inventory does this in a non-threatening way. I don't, as a therapist, you don't have to necessarily ask the person, you know, are you feeling shame? Because that may be threatening. I might say, no. You know, why are you asking me that question? Versus when the inventory person is doing it by themselves and they're answering it by themselves, it may be a more non-threatening way to say, you know, I never thought about that, but I am. You know, I am. And often people sense and they know it, but they don't address it until it's in front of them. And sometimes people won't make the effort to make changes in their life until they've hit a bottom. It can be heartbreaking for families and friends to see people struggle with addiction because they're trying to say, just stop using. And the person is not necessarily going to do that until they're ready, until they've hit their bottom. William James talked about that as one of the conditions that seems to have been common for those who've had a spiritual experience. They got sick and tired of being sick and tired, and sometimes they weren't willing to listen to others. One last point about this. Mark Twain, late Mark Twain, American humorist, said something that I thought was funny but profound. He says, you know, when I was 17 years old, I thought my father he's just so ignorant, didn't know what was going on in the world, and just didn't know anything, and just embarrassing to be around. And when I got to be 24 years old, I didn't realize how much my father learned in those last 7 years. And so we can't always, and he also said that, you know, one of the problems with youth is that it's wasted on the young. So that we can't necessarily transfer over to other people what we see that they're going down. And people with drug and alcohol problems, it's a progressive disease. And I know we might have another session where we talk about the notion of disease, and the terminology is controversial, but I think there's enough evidence to suggest that it is a disease. But it's a progressive disease, and it only gets worse. And it's heartbreaking for family members and people for friends, to see someone continue to go down and decline and use. And regrettably, people may not, and family members or friends feel helpless to do anything. And people won't necessarily do something until they're ready. Until they've hit their own bottom, and one hopes that the bottom is not death.
Yes. Yeah, and I think that that's one of the issues within the rehabilitation, industry, right? That many, especially young people, end up in rehabilitation treatment because somebody else wants them to be there, and not because they themselves are ready, right? And this is not just true of addiction, but any kind of mental health care. That if the person comes in not of their own volition, where they don't yet see a reason to change their behavior, or they're not yet ready to change their behavior, it's difficult. I mean, the classic joke is, how many psychologists does it take to change a light bulb? And the answer is one, but the light bulb has to want to change, right? You know, but it can be very, very heartbreaking and challenging, and parents can say, like, look, I mean, I've, you know, how many tens of thousands of dollars have I spent on sending you to rehab after rehab after rehab, and you're still using, but the kid doesn't want to stop yet.
And that doesn't mean that one can't, because interventions sometimes do work. People get exposed when people are basically told by the courts that they need to go into this particular program. They're ordered to, and sometimes what I've seen as a clinician is that sometimes those individuals will see things and hear things that make it click and becomes a trigger to change where they didn't initially want to. They hear something. But I've also seen individuals who were mandated by court to go to rehab programs, and they did it because they were required to do so, or because their spouse wanted them to do so, and it tended not to last until they found for themselves. And maybe where spirituality comes in is that it's a form of grace to have the desire to want to. There are individuals I've heard that said, I want to stop.
Hmm.
I don't want to stop, I want to stop. And so even in the field of counseling, there are stages that the therapist looks at in terms of their readiness for change. We have generally the 5-stage approach is pre-contemplation, where they're thinking about it, and then they're contemplating, which is so the pre-contemplation is they're not yet even thinking about it. In contemplation, they're thinking about it. Then they're taking action. And the reevaluation, and then a maintenance program. So there's different stages of readiness. And I think what is wonderful for those individuals who have had some discoveries and where it's working, where people are staying sober or not using alcohol or drugs, and they're having reasonably happy lives, because the goal is not just to stop using alcohol and drinking or drugs. In fact, there's a term called dry drunk, where people have stopped using, but they're angry all the time. And what's the point of that? So the goal is not coming back to just stopping using drugs or alcohol. The goal is to have a meaningful, purposeful life, and to look at what does that look like? What does that look like? And often the people who are doing best are people who are have found a measure of peace with, they've made terms with people that they've hurt, or they've done their best. Even if people are not around, they've taken the steps. There are other steps that people can take. That they found a way to clean what is referred to in a 12-step program is to clean the wreckage of the past. And so that they can look in the mirror and be okay with what they see. And then the alcohol or the drugs, what was trying to fill that hole in the soul, because that was what the alcohol and the drugs are trying to do, somehow it no longer seems necessary.
Yeah, and I do love, like, I love this like whole spiritual and like the journey and like these, I don't know if they're metaphysical or if they're just advanced psychological concepts. And like I think that anyone, like I've spoken to a lot of addicts or ex-addicts or however that wants to be phrased, and they're all like, all these things, these ideas are all there, and you know, the way that it's being put together, or like how to like quantify it and all that stuff, it becomes very difficult. And I think a lot of people have different views on it, and there are different stages and all that kind of stuff. And you know, just to like bring it back to the RWI, like the RWI, what it does is it lets you kind of get a snapshot of that person's
Yes.
life. So it's not saying don't do the spiritual journey, or do it, or do it in this way, or don't do it in that way. But it does bring it grounded. It does let you see what's happening within the person. And so the people have to do their own journey, and they have to hit rock bottom, or they have to do whatever it is that they have to do, and letting them, or letting the therapist or the counselor or whoever see these snapshots of what's going on, really, like, it really keeps you like honest and accountable and on track.
It certainly does, or has the potential for keeping people honest. And the RWI does have a consistency scale to look at to see whether there's consistency and inconsistencies. The issue of honesty is something that will surface in the course of counseling, but certainly honesty is one of the important elements to the process. And I'd like to conclude by again emphasizing that for those who are counselors, therapists, owners of rehabilitation treatment programs, that it is that the gold standard in the industry would be to collect data in a standardized, objective way before and after treatment, and conduct the descriptive and inferential statistics, because that's an honest way of looking at, and a scientific way of looking at the effectiveness of treatment program. And I also would like to emphasize that for those therapists and counselors who are working with individuals with drug and alcohol problems, I'd like to suggest that they have an opportunity to have a free trial with the Rehabilitation Wellness Inventory, so that you can see for yourselves the benefit and the value that this inventory has for you as a therapist in terms of treatment planning. And we would be happy to speak with you about that, and to have you have a complimentary assessment and see a report. So thank you for the opportunity to be here today.
Yeah, thank you.
Thank you very much for your time, and I do agree with you that this is an excellent way to improve, to demonstrate the effectiveness of one's program, and also to improve the effectiveness, which is really what we're all doing here, is trying to help people get better and stay better.
So thank you again, Dr. Jonathan Siegel, the clinical psychologist with specialization in counseling and rehabilitation, and Dr. Shayna RWI, clinical rehabilitation and neuropsychologist.